the best practice is to apply this approach called health literacy universal precautions to all your encounters with any patient, with any family member. So just as you would use proper personal protective equipment if you were encountering body fluids, right? You're going to use those universal precautions because you don't know what you're dealing with. The same is true for encounters with health literacy.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS. And today we're talking with ONS member Regina Carlisle, Senior Cancer Information Nurse at University Hospital's Seidman Cancer Center in Cleveland, Ohio, about developing and providing patient education across various formats for patients with limited English proficiency. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Regina.
Thank you, Jaime. It's great to be here.
So to start things off, can you briefly explain the importance of health literacy and the different formats or options for patient education?
Well, I'd like to start with the definition of health literacy. I think this big misconception is that it means someone's ability to read or write. And really, it's much more than that. And there are two basic definitions for health literacy. We have personal health literacy. So that's my ability or a person's ability to find, process, and understand and actually use the health information to do something with it. And then a newer definition that's come out is organizational health literacy. So what's the degree that an organization equitably enables people to find, process, understand, and use that health information? So for my own hospital, I say, how do we help people with their healthcare journey? Is the wayfinding helpful? Are the materials we hand out useful? So it's not just all the onus is on the patient. It's really, we have a part in that as well as the hospital. But there are some factors that make you more likely to have limited health literacy, such as limited literacy skills. If you don't read or write well, if English is your second language, or being older. But I think a big point to really stress is that anyone can have limited health literacy at any time. It is invisible. So that's something, it doesn't matter if you're talking to a doctor, a nurse, someone who has no medical background, we all can struggle with health literacy. And then there's an offshoot of that called plain language. And that means plain language is information that you understand the first time you hear it or you read it. And it applies to all aspects of our life. But in the medical world, we're talking about trying to avoid medical jargon, words with more than 2 syllables, because that can be hard for people, especially when they're reading. If they have limited literacy skills, they might get stuck. Long sentences, more than 20 words in a sentence is probably going to trip someone up. But I think all of us appreciate plain language. We appreciate simple messages. So if you can apply these kinds of principles of health literacy to everything you do, everyone's going to potentially benefit. And then in terms of patient education, I think the most common formats you have your verbal communication, your written materials, your videos, and then these days we're seeing more and more apps that are available.
Thank you for that, Regina. I think it's really important how you created that initial distinction between health literacy and then that other version of the organizational literacy and but it all sort of encompasses our patients' experience with us. And I think, personal opinion, I think nurses, we integrate the concept of health literacy throughout our education, and it's sort of integrated into our practice just as nurses. But I think it is important and something we all should give pause to because, we live and breathe healthcare. That's just sort of our existence and our job. And so sometimes we do need to take that step back and say, would I understand this if I wasn't a nurse or if I hadn't been doing this for so many years? And I think that can take effort because a lot of that jargon and things just rolls off the tongue and we know all the acronyms and we can piece it all together, but it does take an intentionality about asking yourself, what does this patient need to know and how do I need to say it or how do I need to present it so that they can grasp it and integrate it meaningfully into what that means for them in their life?
Exactly. And I think there is this thing called the curse of knowledge, too. We have to be careful because it's clear to us, but is it really clear to the patient? And truly, the gold standard is when you create materials, you have patients review them. We use a patient and family advisory council to look over our materials, even if it's as simple as, does this make sense? Is this clear? They even catch sometimes if I make grammar mistakes. But that is really, and unfortunately in healthcare, I think people are like, we got to get it done yesterday is often the theme. So we don't always take the time to do that. I mean, and really best practice is you involve the patients and the families from the start, whether you're creating a class or again, you're writing a booklet or a handout, they are part of that process.
And I also really liked how you explained clearly that health literacy is not literacy. I mean, those are separate concepts. And certainly I'm sure there's a correlation with, if your literacy level is poor, then likely your health literacy might equally be poor. I think you made a good point that you can't make that assumption because there might be highly educated or very intelligent patients or families, but their area of expertise has nothing to do with healthcare. And so it still might feel like something completely foreign and unknown to them. And so you have to approach everybody with that same inquiry of like, well, what do you understand? Where are you now? How do I meet you where you are so that we can have a conversation at the level that makes sense for you?
Exactly. Yes. You definitely have to level set. You make me think of a story of myself. I'm the person responsible, my family. I don't have kids. I have dog kids, but I'm responsible for when we go to the vet and kind of knowing what the history is and sharing with the vet. And when my dog got sick and I showed up at the vet, I could hardly sign my name on the paper, to give permission. And then when I sat with the vet, they said, oh, we're going to get labs and we're going to get rads. And I was like, what are rads? And he goes, oh, that's x-rays. And I'm like, oh, I should know that. I'm a nurse, but I had no clue because everything was just jumbled in my, because I was so stressed out.
That's a great lesson too, is that even if someone has great health literacy or they should know how it goes or they're in the healthcare field, but when they become the patient or a caregiver or it comes close to them, they still might not be in the right frame of mind to grasp on things as well as they might otherwise. And so again, just an important lesson to approach everyone, assume they don't know anything and find your way to kind of what their level is. And then that's your kind of jumping off point.
Yep. You hit the nail on the head.
So let's talk a little bit about, is there any institutional or regulatory guidelines that nurses should keep in mind when they're evaluating a patient's level of health literacy in preparation for education they're about to present?
Well, I'm active on some health literacy and patient education listservs, and the topic of assessing a person's health literacy does come up from time to time. And the overriding consensus is really that you should not be assessing health literacy. And again, it's that what we said earlier, it's dynamic and someone could be fine today. If there's a new stressor that comes into play, the wheels fall off, their health literacy skills are compromised. Really, the only time you would really probably assess it is if you were doing it as part of research. But the best practice is to apply this approach called health literacy universal precautions to all your encounters with any patient, with any family member. So just as you would use proper personal protective equipment if you were encountering body fluids, right? You're going to use those universal precautions because you don't know what you're dealing with. The same is true for encounters with health literacy. You have a toolkit that actually you can utilize. It's from the AHRQ, which is the Agency for Healthcare Research and Quality. And they have this universal precautions toolkit on their website. And it gives you the basic tools to apply to spoken and written communication, helps you improve supportive systems, self-management and empowerment, and kind of assess where you're at and where you need to be. I think, again, kind of what I was saying earlier is, the bottom line is we don't want to make assumptions. And it's not about dumbing things down. Sometimes people will say that to me. Can you help me dumb down this document? It's not about being stupid. We're all busy. We just want to make information that is understandable to as many people as possible. So that's why when you apply these precautions, which I'll talk about a little bit later, that is going to help you do that. But in terms of institutional guidelines, you should see, does your organization have a policy for patient education or a policy for working with interpreters if patients are of limited English proficiency? Nationally, we do have some rules we need to follow. There's Title VI of Civil Rights Act, and the Health and Human Services have a policy there that say you can't discriminate against people despite their origin, and you can't charge people for these services. So you really need to know that these are things that are, again, the onus is on the healthcare provider to help the patient. And the Affordable Care Act has a section, it's section 1557, that says we are required to give people, especially if we're getting monies from the government to provide our healthcare, we need to provide them with a qualified interpreter.
I'm going to jump back just to your beginning statement, just about assessing health literacy. And I think you made a great point in that, it's just a snapshot in time. It's just, even if your institution does have some sort of scale or assessment tool they use to better grade or understand a patient's level of health literacy, it's still just that single snapshot and doesn't really apply to every topic that you'll have or every conversation that you'll have with that patient. So I do think it's important to do a little bit more individualistic overview of what that patient understands, is able to understand. And I think that's a more sensitive guidance to what that individual patient and their family needs when they're trying to learn about whether it's their new diagnosis or their treatment plan. I think that was a very interesting comment that you made about the assessment.
Yes, I think level setting is really important. Like you have to know where they're at. I mean, of course, there's certain information we're just required to share, right? We have kind of a script for our chemo teaching. There's certain things. But coming into that, knowing, have they had a family member who's had chemo before? Was it 40 years ago when it was really bad and there were lots of side effects we couldn't manage? Like what is their perspective and their personal experience? I think will go a long way in helping you during that encounter for educating.
So let's go a little bit deeper into our patient population that may have limited English proficiency, or perhaps it's not their primary language. So I think most nurses throughout their practice, whether they've been in oncology or other subspecialties, we've all encountered patients that don't speak our own language, or, assuming our first language is English. Can you give any recommendations? What should nurses consider if they're producing or providing materials, whether they're written or printed, for patients that maybe have limited English proficiency?
The first point to consider is, this is extremely important, can the patient or family member read in that language? I have had that come up. I mean, I ask and they say, oh, no, they can't read. Or let me see, they can't, but their daughter can. So before you spend the money and the resources to get these things interpreted or translated, that you want to make sure you have verified that they can read. And then you need to determine what language they read. So for example, in Chinese, the common spoken dialects, some of the most common are Mandarin or Cantonese, but that's not what you translate to. The written forms of the language come as traditional or simplified. And you have some patients that can read both, but not always. So I had that example in the past where I had to verify with the patient, well, which one can you read? Or what do you prefer? So I think this would be a good time, because I just kind of tripped up earlier. I need to clarify, what are the definitions for interpretation and translation? And I think we use them interchangeably, but really interpretation is talking about the spoken language, right? You use an interpreter. Translation is usually referring to the written information that you're translating. These written translations, this has been a learning curve for me in my job. They can take time and money to obtain, so you may be using internally, you may have a resource, but if not, you're going to be using an outside. Maybe it's an organization like the American Cancer Society or National Cancer Institute has something in another language like Spanish, or you're using a company that you're contracted with to provide that. But one thing that's really important, no matter where the resource is coming from, but especially if it's an outside resource, you need to verify that it's accurate, just as you would for an English-speaking patient. So I'll give the example here. When we teach people about a fever, we say 100.4 degrees is a fever. Anything that number or above, you need to call your doctor right away because it might be sign of an infection. However, if I pull a handout from another organization, it might say the fever is 100.5 or 101. And so I need to vet that before I hand that over to the patient. Also, some patients from other countries use Celsius instead of Fahrenheit. So we actually write 100.4 or 38 degrees Celsius. So you just want to make sure that that information is correct and it's aligning with your practice or your institution's policy. And then again, the rules that you would use for documents that are in English, you would want to use for documents in other languages. So things like health literacy friendly design, you want font size that's big enough, at least a 12-point font. You want to use things like Times Roman or Arial. You don't want to use cursive, or some of these other fonts that are hard to read. You got to be careful with color. Black on white is your best bet. sometimes people like to use red writing or different colors, and that can be more challenging for people to read. You got to be careful with your white space, your margins, breaking up large pieces of text. And also, a lot of people like to use bullet points, but you don't want to get bullet fatigue either, where you use the entire page is full of bullet points. So there's lots of little tricks, again, that kind of come from just working in that health literacy and plain language world that, you want to apply equitably no matter what language the information is in.
I think those are all great tips. And like you said, it's whatever language you're writing these patient education materials in, all of those things are very important. And I know that my experience has been that not all institutions are equally focused or budgeted to have top-notch, professionally created patient education materials. And so what do we do as nurses? We make them ourselves because you got to have something, right? So I think those tips are really important. And certainly we could probably have a whole separate discussion just on that. But it is, I think nurses are doing their best to create handouts or printouts or something to give the patient that helps to list all the information. But as you said, there's lots of things to keep in mind when you're doing that. Even if it's in your native language of English, there are ways to do that that are easily received, that can improve the patient's ability to understand what's being said on the page. We just have to keep all that stuff in mind. And it's not, again, it's good intentions. That's not meant to make anyone feel bad, but it's sometimes there can be better ways to create those documents and share them with patients. And as you mentioned, ultimately getting them looked over and approved by patients to say, yes, I think this works. This makes sense to me. This helps me understand can always be validating. So in the world we live in now, there's lots of technology that we haven't always had. So things like apps on phone, Google Translate, how is that impacting the ability to provide education to patients that don't necessarily have English as a primary language?
Well, my experience is that they can be a problem. You just don't know their accuracy. And I'll give you my own personal example. So I was in Japan and I tried using Google Translate and I used another foreign language app. And I was at a restaurant and I was scanning a menu and I was using both tools and I saw errors. So the menu said beef, chicken, shrimp. I'm like, okay, we're good. And then I saw eyelash on the menu. And I said, I'm fairly certain they weren't serving eyelashes. So I think that someday we may have accurate tools, but we're just not there yet. And so we really need to rely on qualified humans for these interactions, whether they're in person or they're like a video virtual interpreter or on the phone, like a 3-way phone call with an interpreter.
Yeah, I mean, I think, again, people are trying to do their best and perhaps casual conversation of like, where's the bathroom? Like these types of translators are probably safe to use. But when you're talking about complex terms, medical terms, things that have serious implications, you don't want to get that translation wrong. Your caution is deserved. And I think everyone, I'm sure, knows that their institution likely has a policy of what they can or cannot use when they're having patient interactions. How should they speak with patients that don't speak English? And as you mentioned, sometimes there's a 3-way telephone. That was sort of the original version where you have an actual 800 number, some number you call, and you're able to get that interpreter. More often now these days, I've seen this, the iPad kind of video conference that gets wheeled around and you can actually see the person, which I think is obviously a huge step forward. But I know often out of convenience or out of no other easy option, nurses are often compelled to turn to their teammate who happens to speak that language or the family member that's with them and ask them, can you translate this communication? What did they say? Or can you tell them I said this? What are your recommendations or advice in that situation?
So that is another one. There are national or international best practices that really advise against using family or staff for translations because there's several reasons. They might not know the medical terminology, or you might be putting them in an uncomfortable situation. Plus, there might be cultural norms or family dynamics that affect that conversation, and they affect how the information is delivered between you, the family member, and the patient. It really can muddy the waters. Now, I know in our institution, if there's a medical emergency, there can be an exception, but that's really not best practice to utilize them. So I, again, suggest seeing, does your organization have a policy? Also, do they have a policy about using staff? Because it may be only allowed if the staff are qualified. There are definitely nuances to interpreting. Plus, there's a code of ethics that they adhere to. So that's probably something, most people, yes, they're bilingual, but are they a qualified interpreter? And that's really what you want to use whenever possible.
Yeah, I think that's really important to make that distinction. And family members obviously mean well, and they'll be there. And after you leave, they will interpret whatever they heard. You can't stop that from happening, but to use them and to put that sort of pressure on them to say exactly what's being said. I mean, in the scenarios where you're delivering perhaps bad news or serious news, that can be very ethically challenging for a family member to have to be the one to essentially say that. And then, like you mentioned, are there cultural limitations that don't allow them to say certain things, or just there are reasons that could influence the message. And we want to make sure that the information we're providing is accurate. And I think, as you mentioned, sometimes there are programs that staff can go through to be, officially trained and be deemed at that qualified interpreter. But I agree with you that I don't think it's fair to put them in that situation either, even though they're not a family member or related to the patient. They've got a job to do, and that's not it. So I think it's just important.
Yeah, that's a great point, though, too. I mean, a health literacy friendly organization, back to my original, definitions, wouldn't that be great if they supported their staff and said, if you want to get certification as a qualified interpreter because you can be utilized throughout the hospital, we'll support you in that. That to me would be something fabulous to offer to employees.
Absolutely. Well, and if they do speak the same language, that could be that they share a community or maybe have other things in common, and that could make them feel more comfortable with that person who is translating for them. But again, it's just, we want to make sure that that person is set up for success to understand, what their role is in that very defined interpreter role. It's important to give them the training and the support that they need to do that work effectively. So could you maybe elaborate on a few situations where you've encountered patients that have limited English proficiency, and how did you and your team work together to bridge that communication gap?
Sure. So I had a patient, and I've alluded to this earlier, who spoke Mandarin. That patient presented to a chemo class, a group chemo class at the time. And I was like, this isn't going to work. This needs to be one-on-one. So I set up a separate meeting with the patient. It took time to get the interpreter. In our hospital, we use an outside agency. So I had to coordinate that. But in the meantime, we looked at what key materials would we want to get translated, the written materials. And then in that actual interaction, it took me about double the time to teach the class. And it kind of dawned on me as I was that was the first time I had to teach the class in another language, was he really would have benefited from having, and I advocated that he would have a live interpreter at his first chemo infusion. So that again, even though family might have been there, it was the fact that, it's stressful. There's lots of things that we're trying to communicate. The provider is probably meeting with the patient first, then the infusion nurse, just getting oriented to what to expect, having that live interpreter there, or if there was a problem, it became a very valuable resource. And in another instance, I had another patient who presented to the class, and first it was a group class, and it was kind of hard to figure out at first. She presented alone, that she spoke a dialect that was pretty uncommon. And when I actually had to do a little bit of digging, I found out that the phone line did not have anyone who spoke that language. And the virtual system, they had someone who spoke that language, but wherever they were at, they were so remote that they could not get on the video screen. It was just going to be a black screen with the person talking, kind of like a phone call. So I had to do all that digging and figure that out, and then tell the team, because now they were going to have these interactions with the patient. And she sometimes, again, she said, well, I normally my nephew's with me. I said, well, we need to make sure we've got the resources for you. So it was putting that information out. And I think, unfortunately, there was actually just an article in the Clinical Journal of Oncology Nursing that was talking about limited English proficiency. And they gave a case example where they said the patient showed up and the staff kind of didn't know, right, that they needed an interpreter. So I think that that's another important piece, is kind of making sure that we're all doing the handoff. We're telling the next person, and that could start with a scheduler, or it could be the nurse in the clinic telling the infusion nurse, you need this. You don't want these surprises. So the more that we can be prepared, I think the more it sets all of us up for success.
You hit the nail right on the head. It's an important part of coordination of care. And I would say it really falls into that initial barriers assessment that we should be doing for our patients to understand, what barriers do they have to completing their care as they need to? What would limit them from being able to do that? And clearly a language barrier is a huge issue. And so, as you mentioned, a lot of times that information is either somehow already documented in the medical record. And so that flags your scheduling staff, or it somehow creates that awareness. But even if it doesn't, passing that information on from team to team, proactively setting up, the services in the translator that, or the interpreter that is needed. All of that can help just make that experience for the patient seamless and, support the staff so that they can feel like they can do their job well by having that issue kind of addressed ahead of time so that it doesn't come up in surprise and kind of derail the day while they're waiting for those resources to show up. So certainly important to keep as sort of a proactive part of the assessment for a patient when they first arrive to understand what needs might they have throughout the rest of this treatment journey. So we maybe touched on this a little bit, but maybe not quite directly. How should nurses evaluate maybe their inherent implicit biases when they're preparing to provide education to a patient who has limited English proficiency?
Well, I think it's important that you just acknowledge that it's real and that you can't know everything, and implicit biases, they're everywhere. And I think it's very much about just recognizing cultural humility and that you have this awareness of your limitations. And if you see the areas for improvement, there are definitely opportunities to educate yourself, expand your horizons. And I'll mention a little bit later in the resources, one way to do that.
Wonderful. So let's move on to that then. So what resources do you recommend to help better equip oncology nurses to care for patients with limited English proficiency? And do you have any tips or best practices?
Well, I think we've touched upon some of these, but just to reiterate, it's using qualified interpreters and qualified translation services. So back to the interpreters, they could be in person, they could be via video or phone. And you check with your hospital. Again, you may have, we do have live interpreters, but only for patients who speak Arabic, and they have to be tied in with our international services office from the start. But we use an agency for anyone else. But that takes time. You have to coordinate that. If you're going to use a translation service for written materials, you just know that it can be expensive. And I wish there was a magical bucket of money that you could just translate everything. And I've talked to educators at hospitals all over. We're all kind of in this same boat. So you really have to kind of prioritize what needs to be translated, what's important for us. We look at some of the key things that we use to teach people about signs of infection, when to call their doctor, what to do if they have to go to the emergency room. We have safe handling of body fluids at home after chemo. I mean, that's important information that I don't expect people to memorize all that. So if I can have that in Russian or Spanish or Chinese or Arabic, what we did is we surveyed our nurses out in the community. We said, what are the most common languages? Spanish and Russian were the top two for us. But some of those translation quotes, I've had $125 a page easily. And again, less common or more obscure languages might cost you more money. And if you have to rush the job, that's going to cost more money. So you can also look internally. We use a lexicon for our medication education. They have that information in about 12 or 15 different languages. So start there and see if they have what you need, or look within your institution. Do you have something at your fingertips and maybe you just didn't realize it was there?
I think that's great. And I think a huge takeaway for me as I listened to you was don't wait until that patient is scheduled to come in tomorrow to see what you have for them. As you said, do maybe that just needs assessment of what's the most likely, scenario? What type of languages might I see that I could be prepared for, or at least know the process? I need to know how to get in, linked in with interpreter. You have to know what's the process. It's likely there's going to be a policy to find, or a phone number, or some sort of order or process,
or an account number you have to give in order to access
exactly.
it. Do it now. Don't wait until you don't want to be caught flat-footed trying to do it in the clinic. So try it and see how it works, and then you'll be more comfortable when that time comes.
Absolutely. And as you mentioned, every community is different. So wherever, you listener are and the community that you practice in, understand what your populations are and who is likely to come seek care from you. And you likely already have an idea of that, but, it's important to understand, in terms of the catchment area of your institution or your organization, what populations, what cultures do you have, and how can you be prepared to care for them and have materials for those individuals when they come to you, just as much as you can work ahead to be ready. Will make it, again, a seamless process for that patient so they don't feel like we're scrambling at the last minute to find a piece of paper to give them that has some words that they're familiar with. So the more we can do ahead of time, the better.
That brings up another thing that someone just brought to my attention was we are seeing more community health navigators for patients that are immigrants. And they are saying, well, they're going to be coming to appointments. They're going to be helping patients. Can they do the translating? And I said, well, are they qualified? Because if they're not, we still need to have, according to the policy, and we need to have that qualified interpreter there.
So again, just important to know what your policy states, what the requirements are, and how you can ensure the people that are fulfilling those requirements do have those qualifications. Well, Regina, thank you so much for all of the information you've shared today. I've certainly learned a lot. And as we approach the end of our episode, we like to always ask a few just sort of quick fire questions to summarize what we've talked about. So to start things off, what are some common misconceptions about educating patients with limited English proficiency?
That it's okay to use family, staff, or Google Translate. They're not. They're really not okay. And I think another one is know your rights within your institution. So for our policy, I can insist on an interpreter. If I feel like it's necessary, even though the patient may want to waive it, I feel like I need it to understand or communicate or do the teach back method. That is something that I can insist upon.
I love that. And I think that's so important because it benefits both the patient and the clinician, right? It's for both sides benefit. And it's not just if the patient wants it. So that's, I think, a great reminder that we should be standing up for what's right. If it helps us deliver our message clearer or it helps the patient understand what we're trying to teach them. What's something about this topic that's not often discussed, but you wish people knew more about?
I think there is some etiquette for using the interpreter that isn't always discussed. It's good to brief them before you start and even do a debrief afterwards. But just kind of setting the tone at the beginning for what you're going to be discussing, letting them know they can interrupt you if they have questions. I think another thing within that interaction with the patient is they are not required to memorize all this information. Offer them a piece of paper and a pen, especially if you don't have everything in writing. You want to encourage them to ask questions and give yourself double the time. And another thing I think with interpreter, it's not always understood that you really should probably just go like sentence by sentence and allow for that interpretation. The more you spit out, the more they have to try to interpret, a chunk of information and then get perhaps a patient feedback. So looking at the patient, maybe setting the interpreter behind the patient or next to them can be helpful. And this is tricky, but you have to be careful that you are still speaking to the patient. Like you don't want to say, ask her, you're looking at the interpreter, ask him. You want to just look at the patient and talk to them just like you would normally talk, just pretending like the interpreter is not in the room and still using your teach back because that is your only way to confirm understanding.
That's a great reminder of, it's going to be kind of an awkward exchange when there's a third person in the conversation, like trying to be the conduit. And so we can just embrace that. And we know it's not going to feel as natural as a one-on-one conversation, all in the same language, but we still do the best we can. And so I think those are some great tips to remind people that, maybe even just kind of practicing through what that's going to be like, thinking ahead to how you need to, as you mentioned, give the interpreter sort of a summary of what the situation is and what the plan is, and just creating that comfort of this is maybe something new or different for me, but we're going to do our best to make sure we share the right information. So those are some great tips. What additional training or education do oncology nurses need to better understand developing resources for and educating patients who don't speak English?
It would be best to start with the health literacy toolkit that I mentioned because those principles do apply broadly. And then if you want in-depth training, there's Think Cultural Health, which is from the U.S. Office of Minority Health, and they give e-learning courses. And there's one specifically for nurses about culturally and linguistically appropriate care. They call it CLAS, C-L-A-S. So that would be really a great starting point.
Wonderful. And do you have any additional resources for patients or providers who want to learn more?
Yes, I have a bunch. So I know you'll share this on your website, but you have the Institute for Healthcare Advancement. They call themselves IHA. They have a great health literacy listserv that I follow that, again, this topic comes up often. There is the Cancer Patient Education Network called CPEN, which is made up of cancer patient educators across the country, and they have a very robust listserv. I mentioned Think Cultural Health. That's from hhs.gov. Our friends in Canada have culturallyconnected.ca, which has a lot of great resources as well. And then there is a website. I'll give a shout out to Ohio. I went to Ohio State. So our friends down in Central Ohio several years ago put together a website where they pulled their resources together and they have a lot of translated materials on there. It's called healthintfotranslations.org. And it's not just cancer. There's all kinds of different topics. Many of the sheets, they display side by side. So you have English on one side and you have the language, the translated language on the other side. So you know what you're teaching. I mean, that's really important. So I think that is good to check out. Because again, if you're in a bind, maybe you can find something quickly on that website. And then there's a great book called The Spirit Catches You and You Fall Down that really just gives a lot of insight into an experience of someone who was not from the United States, did not speak English, an entire family, and their experience with the healthcare system.
I, first of all, want to check out that website you mentioned and now that book too. So I've got some things added to my reading list to check out. Do you have any final comments for our guests today?
Just again, to kind of reiterate, know your resources and know your policy. You really just don't want to be caught off guard if the situation arises, and it will arise. You will need this. And again, those same rules of health literacy apply no matter who you're working with. You plain language, avoiding medical jargon, using your teach back, encouraging those questions and note taking. I just think those are all things that we need to just kind of push ourselves and remind ourselves to do every day. And I really appreciate this. I thank you for the opportunity to share. This has been fabulous.
Absolutely. Well, thank you so much, Regina, for sharing all of your information and your time with us today.
Take care. Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.